It is my great honor and privilege to welcome Dr. Huihui Ye from Department of Pathology and Laboratory Medicine at University of California, Los Angeles. She's currently associate professor and also a genitourinary pathologist at UCLA David Geffen School of Medicine. So Dr. Ye got her MD from Zhejiang Medical University in China in 1995, and after several years of practice in China, and then he came here to do a graduate study and get her Master of Science in University of Pittsburgh, and then she moved to New York University and got her AP and CP training, and followed by a genitourinary pathology fellowship at Johns Hopkins. And her first effective appointment is in Best User Deacons, and focus on the GU pathology, and then last January she moved from Boston to her current position. So she's very active in many local and national, international committees and organizations. Her research is mainly focused on the diagnostic biomarkers and the molecular features of the prostate adenocarcinoma. So I think she has a unique way how to approach the research with her daily practice with a more advanced molecular technique. Today she's going to talk to us about the personalized medicine with molecular pathology, especially in prostate cancer.
Good morning, everyone. Thank you for the opportunity to. I'm very honored to be here. Minnesota is such a lovely city, and you have very lucky. You see the river when you want to during the day, which is very nice. Very humane way. Sorry. So I try to be, cutting down some slides because I always prepare too many slides. So don't worry, I will skip some of them and leave some time for questions. So I have a disclosure because I'm on the advisory board of Janssen on the phase 3 clinical trial of this epalutamide trial. So the talk will cover renal tumor as well as prostate cancer. I kind of focused on the prostate cancer when I was in Boston. Now I kind of step into the renal tumor. So I think I just take this opportunity to really learn what my direction of the research is going to. So there's a brief summary. So the renal tumor is a long time being known as both genetic as well as metabolic disease. So it's a very unique cluster of tumor that I felt fascinated once I step into that door. It is quite different than the prostate cancer, which appear to be boring actually. So I will cover renal tumor with the clear cell features in the differential, particularly with the genetic background. So this is the 2016 classification of the renal tumor, and for the community pathologist, which is not in this audience, but actually it was intimidating because the classification is becoming more and more closer to the HIMPAS kind of classification, which is daunting. For the common, renal tumor, actually the common ones are always common, so usually it's not a dilemma. Usually you should say, okay, this is clear cell, sound out. This is papillary, sound out. Chromophore, sound out. But you could have those rare zebras that you wouldn't know what is the latest classification. So I'm going to give you some, features of what those new zebras are. For the clear cell, usually the clear cell renal cell carcinoma could have all kind of differential, including the papillary chromophore and those the terminologies below. But really, what you need to know for our trainees, the important 3 things to be remembered to be able to tell is a clear cell renal cell carcinoma. You could diagnose on PGY1. And then, the hereditary leiomyomatosis renal cell carcinoma associated renal cell carcinoma, because this carcinoma basically kills patients in average of 1 year to 1.5 years and has genetic background. So this you need to remember. Then SDH deficiency renal cell carcinoma, also you need to remember, not because it's lethal, but also because it's genetic, it's hereditary, and patient should be watched out for other malignancies like GIST and pheochromocytoma. So that you need to remember. All those other zebras, you know, if you make a minor differential diagnosis mistake, not that terrible. So I think I will recommend this, you know, this bottom paper for the residents to, as a, you know, like coffee time, Sunday morning read, as a metabolic perspective for renal cell classification and mechanistic view. I love the review. It is last year, oh no, now it's 2018, the year before. They published in this, the nephrology Nature review. So basically, look at this. I hated this diagram when I took the step 1. You know, back in the medical school, it's like my nightmare. However, basically, it is this is mitochondria in the green, and outside is cytoplasm, and focus on some name is gray shadowed, which is fumarate, succinate, and D2 hydroxyglutarate and L2 hydroxyglutarate. Those are basically is oncometabolites that is really hazardous for our health. Those are the carcinogens generated because of malfunctioning of the TCA cycle. So that's a take-home message. All right. So so you could see those gray shadowed boxes, fumarate, could be accumulated by the enzyme deficiency by, you know, the FH. Let me see, here we go. So FH deficiency lead to fumarate accumulation. SDH deficiency lead to succinate accumulation. And some other enzymes named D2HGDH or L2HGDH, those enzymes also could be seen in the RCC that lead to oncometabolites accumulation. So basically those mutations are frequent deficiency genetic background for the renal cell carcinoma. So the mechanistically, those oncometabolites, most important thing is epigenetic action. So it modulates those enzymes, demethylate DNA as well as histone. So you mess up those enzyme activity, you lead to epigenetic shift from, you know, activation or turn on those tumor suppressor to suppression of the tumor suppressors. So leads to carcinogenesis. Those are the most important take-home message of those oncometabolites. However, there are, you know, antibodies like specific functions in different personalities of different oncometabolites. So, so there are some important enzymes. You see that there's the FH deficiency that I just mentioned. It could be lethal, kill the patient in 1 year. So this leads to fumarate accumulation. And the fumarate accumulation is a very versatile oncometabolites, lead to TAT inactivation and leads to the hypermethylation and lead to EMT, epithelial mesenchymal transition. And fumarate also leads to other, you know, demethylation enzyme KDM, and also lead to the histone demethylation. And the succinate act on the TAT as well, lead to hypermethylated phenotype. If you look at the TCGA RCC classification, there is a classification subtype called SIMP. Basically, it is CPG island methylation hypermethylator. So those subtype is most lethal type. It is a subset of type 2 papillary cell carcinoma. Leads to hypermethylation, leads to messed up genome and hypermutations. So that's about the mechanistic view. So let's talk about CCRCC clear cell that I said, PCY1 could diagnose CCRCC. It's a prototype of our metabolic cancer syndrome. Has a long history, and the Nobel Prize winner was on this HIF1 pathway discovery this last year of Nobel Prize in medicine. So it is a von Hippel-Lindau protein with the genetic loss of 3P and inactivation another copy. So biallelic inactivation of von Hippel-Lindau protein. So this protein is basically it's a garbage collector. So garbage collector collect those HIF1 alpha, HIF2 alpha, and get the degradation. So when the garbage collector is on strike, your oncometabolites as well as the HIF1 alpha, HIF2 alpha getting accumulated and turn on the downstream targets. So this is the schematic view of those HIF pathway, and the von Hippel-Lindau complex is a protein complex and composed of the key actor von Hippel-Lindau as well as other subunits, including the elongin C, which I could mention later, and leads to dysfunction of the whole complex and HIF1 alpha, HIF2 alpha overexpression or say accumulation, and lead to pseudo-hypoxic phenotype, which is manifested by VEGF upregulation, GLUT1 upregulation, and TGF-alpha upregulation. So the drug design for the CCRCC is to focus on the HIF downstream targets, including the VEGF, which is really very popular nowadays to treat metastatic clear cell renal cell. And hopefully on the horizon, University of Texas, they did on clinical trial of a new small molecule inhibitor to inhibit the binding of HIF1 alpha, HIF2 alpha, which could be upper there because VEGF is low there, is the downstream target. So hopefully that will be more effective in the CCRCC treatment. And this is a view of a normal high oxygen condition. The cells use the glucose and very efficiently to produce 27 copies of ATP, and all those glucose are used very nicely, clean energy. But when you have the pseudo-hypoxic condition, it's dirty energy. So basically the glucose is not going to be burned completely, but stop at intermediate. And those intermediate will be used for the cancer to build quickly the lipid and protein. So that's why the CCRCC that has a lot of lipid in their cytoplasm leads to the clear cytoplasm. So that's one of the reasons that cell is clear. Another reason is the GLUT1 is upregulated downstream of HIF1, so also lead to a lot of glucose in the cytoplasm. So that's why it contributes to the optically clear cytoplasm of CCRCC under the microscope. And also, the metabolic reprogramming is manifested by this reverse of the TCA cycle. So your engine is reversed. So you can imagine how messed up the cell metabolism would be. So those differentials I could basically just briefly go over. We don't have to because I have another slide session with the trainees. So basically the clear cell is a very versatile tumor. When it's conventional, it's conventional. It's very easy to diagnose. But when it's dedifferentiated and high grade and losing those prototype morphology, you could be just scratching your head and have no idea what type it is. Oftentimes, pathologists could diagnose as unclassified, but if you send to the cytogenetics, that actually has a phenotype of clear cell renal cell. So this is what it looked like, very yellow, golden yellow. I want to see every trainee describe the tumor, CCRCC, as golden yellow, the key word. So golden yellow, remember, is because of the GLUT1 upregulation, lead to glucose accumulation as well as lipid accumulation. So this is a very good gross picture diagnosis. So this is the typical feature of a textbook clear cell renal cell carcinoma that PGY1 could diagnose. This is actually a real case I encountered, and this was from a UCLA graduate student, and when she was 16-year-old, she had one part of the tumor or kidney removed for this tumor. So she had von Hippel-Lindau syndrome. So what I mean, look at this morphology, you could scratch your head, what is this tumor? It could be pseudopapillary, truly papillary, it could be spindled, and losing those all original morphology. And so please, trainees, don't order IHC on those slides. It will be negative for CA9 or patchy CA9, and then you say, oh, what is this tumor? And even PAX-A sometimes could lose expression. So please, don't order, you waste our effort on those classification IHCs on the high-grade tumor. But choose those areas. You look carefully before you order IHC. So those prototype or textbook type, those are giving you the good diagnosis because they read the book. So what we see a non-diffuse positive, CK7 negative, CK negative. So look at this tumor. This is a 72-year-old female and 7 centimeter. Golden yellow, yes? Golden yellow, huh? Hemorrhagic. Look at this. Is that clear cell? Trainees? Okay. What is this feature? I know you know. Yes, rhabdoid. Rhabdoid. So it looks like you know, the rhabdomyosarcoma, well differentiated. You have the dense eosinophilic cytoplasm, prominent nucleoli, and nuclei located eccentrically. So this is rhabdoid. Rhabdoid is bad. This is a differential. I'm not going to go over very much details, but if you want this copy of the presentation, I'm happy to leave you to the trainees to go over because it could be difficult. Okay, so this is just example of this multilocular cystic renal cell neoplasm of low malignant potential. No expansile tumor nodule, very scant those tumor cells, but genetically they are the same. They have those CA9 overexpression and von Hippel-Lindau somatic activation. And MIT, translocation, renal cell carcinoma, TFE3 overexpression, papillary and voluminous nuclei high-grade. And tubulo papillary, clear cell tubulo papillary, which is now similar frequency as the chromophobe. Don't, you know, you need to really know this tumor well because this tumor is indolent. And reverse orientation of the nuclei at the luminal border and tubular papillary structures. And CA9 is cup-shaped or goblet-shaped, and CK7, CK3 positive. So this is the one type that we try to understand at UCLA, TCP1 mutated RCC, and overlapping with the clear cell tubular papillary renal cell carcinoma, and it has those that very prominent muscular or fibromuscular subtype, and with the tubular and papillary architecture, and the CK7 could be patchy, could be extensive. So this is initiated by Dr. Reuter at Memorial Sloan Kettering, and basically from one genetic paper and TCGA cohort, they found that this small subset of the CCRCC was originally diagnosed as CCRCC, but don't have the karyotype of CCRCC. So what they are? They have the characteristic isochromosome 8 or 8q loss. So what is on the 8q? That is what we mentioned before. It is elongin C. Elongin C is the one subunit of von Hippel-Lindau garbage collector. So, and also is a subunit for the polymerase 2. So basically, phenotype very similar to the clear cell renal cell carcinoma. You're not going to diagnose on the clinical practice, but just you could say, oh yeah, this raised the possibility of TCP1 mutated RCC, just knowing that zebra. This is like different pathogenesis leading to the same HIF1 alpha upregulation pathway. So we basically try to understand what is the mechanistic will be different. If you distract, the multipolar multimer, and what is the difference between multipolar deficient versus TCB1 or elongin C deficient? What is the mechanism? So we may need to dissect out downstream which target is differentially expressed, so on and so forth. That is the goal of this project. So this is one example. Multinodular, thick capsule, septate, extending into the tumor, and golden yellow as well, and is indolent. Usually it's indolent. However, in our cohort, we see lethal cases, but those lethal cases, at least at this time point, I would say there is some subset of the tumor gain 3P loss, multipolar deficiency. So let's wait and tell. Maybe next year I will have a better story to tell. And so look at this one. Is that golden yellow, trainees? Yes or no?
Yes. Mustard yellow.
Yeah. It's not golden, yeah. Anyways, this is a 12 centimeter tumor and looks like a granular and discohesive and falling apart, encapsulated. All right, and maybe have some necrosis, hemorrhage. All right, look at here, spindle cell, sounds familiar. Rhabdoid, sounds familiar. Looks like clear cell at the lower grade area. Sounds familiar again, so who is kidding us? All right, I'm not kidding because there are other areas that are shown here. It's good papillary architecture. All right, so this is a great mimicker. Papillary renal cell carcinoma could just look like clear cell. And you have the different, sub areas that of the tumor. You sample extensively, look for the well-differentiated area to order your immuno, and this immuno is typical for the papillary renal cell carcinoma. So don't be fooled by the clear cellness of the certain field, but look for characteristic low-grade area for clues for diagnosis. So this is the evolving classification. Basically, I'm going to tell you my job is difficult. Your job will be more difficult in the future because I still make the diagnosis on morphology IHC. Maybe later on you have to read the next generation sequencing to make your diagnosis, but that's a trend. So here the trend is the molecular phenotype or molecular genotype is going to be incorporated into the classification because those subtypes, newly stipulated subtypes, they have subtype-specific prognosis, subtype-specific treatment choices. That's why we need to learn those subtypes. So CCRCC now split into CCPRCC, which stands for clear cell papillary renal cell carcinoma, indolent, never goes to metastasis. If you see a metastatic CCPRCC, question the diagnosis. Get the slides and get stains and see whether this is the correct diagnosis or not. And TCB1 so far is indolent. We'll see whether it could be lethal. And papillary type 2 split into this translocation renal cell carcinoma, FH deficient renal cell carcinoma, which has a syndromic presentation, and ALK translocation renal cell carcinoma. Rare zebra. However, we have good drug that you need to remember because ALK1, the inhibitor, is good for those patients, and those ALK translocation RCC are aggressive. So this is a treatment-specific diagnosis. I think I'm good on the time management. All right, so switch to the next chapter, which is my old chapter as a prostate cancer. I have been working for 8 years as a surgical pathology. So I think my role, because I don't have a PhD, I have a master's degree, and I love morphology. I'm not going to give up my morphology. So my role of those translational research is a bridge. I kind of, I come to see all kind of research group and I give them my idea, what could be a good research question, and let them figure out. And then validate on my, slide. So basically, our research could be very useful, but not too complicated. So that's what I try to, design my future research career at UCLA. I'm not going to be right R1 grant for sure. So this is the NCCN guideline. You see those guidelines becoming thicker and thicker. If you print out a paper, basically it's a novel. It's like 100 pages thick. Seriously, this is becoming like killing a lot of trees in the future because the guidelines is more and more and more details. This is a very busy table, and nobody is reading those small fonts as if those disclaimers. But really, those small fonts sometimes are important. So this is when you diagnose a patient with prostate cancer at the prostate biopsy, you really need to knowing what kind of prostate cancer need to be treated, what kind of prostate cancer, leave them alone or actively watch it. So our pathologists play a very key role in this triage of the prostate cancer in the modern era by PSA screening. So remember, our importance is not really just reporting it, but identifying what is critical features for patient management in those tumor that is hit the male population as the first most prevalent disease in this world. So our role, it is very important to understand what are the bad features for the prostate cancer. So new things here in this busy table is one thing is very important is genetic. Now we know that a lot of lethal prostate cancer has genetic background, familial background. BRCA1, BRCA2 mutations. Once you see those intraductal carcinoma or very aggressive primary pattern 5, really the clinician, if he's practicing up to date, need to figure out whether the familial history is there and genetic counseling. So this is incorporated into the clinical management. And larger purple pattern 4 also is a bad player indicating bad prognosis, genetic background. All right, so this is the key point, that we understand what is the genetic feature, correlate to our morphological finding under the microscope, report it reproducibly, and tell the clinician, I observed this phenomena, and you need to test this, you need to work up, you need to ask for a familial history.
Wow.
So, so nowadays, we actually active surveillance a lot of prostate cancer. Maybe like 70% of the patients should be managed by active surveillance. 336, 347, those are safely managed if the cancer volume is low, PSA is not super high, MRI is not a big tumor, not EPE. So those clinical features telling you that those patients could be just watched closely, not just watchful waiting, but actively managing by repeat biopsy, repeat MRI, and repeat pathology diagnosis on the biopsy material. Until the pathologist said, okay, here we go. This patient has large purple pattern 4. This patient cannot be managed by active surveillance. This patient has intraductal carcinoma, cannot be managed by active surveillance. This patient has EPE detected on biopsy, no active surveillance. This patient has LVI, no active surveillance. So those also predominant ductal differentiation. So those are the kick-out features you need to really put down on your diagnosis and educate your clinical colleagues, knowing the significance of my wording and bold it, highlight it on your report. So multimetric MRI UCLA is a pioneer in this technique, and as well as NCI. So I'm proud that the UCLA has been, very upfront in this technology. Nowadays, a lot of prostate cancer we diagnose at UCLA is coming with this radiology report. We incorporate pathology report with the radiology report, so the patient receive an integrated diagnostic report covering both first few pages pathology report, several pages is radiology report, and it's automated. So you don't have to, like pathologists, generate those reports. Just, all the computer does it for us. So we don't like switch back and forth into interface to generate that integrated report. We just send out in bigger.
Does the PSA value factor into your report?
That is in the clinical information. So usually the nurse put the clinical information on the clinical part. They put it into the beaker, and we put our pathology diagnosis, and radiology put the.
So the PSA is not part of the treatment algorithm.
It is in the treatment. So if you go back to the risk stratification, if the PSA is above 20, this is a risk factor that it should be factored in. So basically, this is, I'm not the person to present this technique because it's so complicated. Basically, they use the molecule diffusion and the enhancement and tumor nodule size and come up with the PIRAT score. PIRAT 4 and 5 are good, high risk category for high risk prostate cancer. PIRAT 1 to 3 usually is indolent tumor. So they are almost, catching up to us. Because we diagnose those on the histopathology, they give a very near perfect diagnosis on the radiology, on the grading as well. So, and also if beyond our pathology, the oncologist and the urologist oftentimes request for other molecular tests, which they often use, like back in Boston, they sent to Oncotype DX and Polaris. And here at UCLA, they send to Decipher. I don't think there's big difference between those kits, just customer relationships, and you like to send to which company. But indeed, those have scientific background and also lead to a whole slew of discovery. So it is good that commercial company is catching up on translational research as well as discoveries. So, as we said before, genetic thing is a big thing now in the prostate cancer, ovarian cancer. So if there is those features, introductal larger performing pattern 4, that indicates that genetic background should be checked, BRCA1, 2, and as well as those mismatch repair gene deficiency in the background. And homologous recombination gene deficiencies as well. So, ATM, PALB, and CHEK2, which you're familiar with. So, very confusing terminology in our clinical diagnosis. I think it is the stupidity of the terminology of earlier experts, but generate this dilemma. I just want to go through it because this is so confusing to a lot of even fellows, and the urologist questioned me like multiple times. So high-grade pin-like carcinoma, ductal carcinoma, and intraductal carcinoma. The terminology is really like overlapping and confusing. So this is a paper that Ming Zhou, my 大师兄, the first senior trainee of Dr. Epstein. He is basically really a big star in the GU pathology, and he wrote up this paper. This is really good for the trainees to go over. So this is ductal carcinoma. So the feature of the ductal carcinoma, it is cribriforming, very blue at low power, either cribriforming, densely cribriforming, or papillary. Okay. Look at it, this is a high-grade tumor. Without the GU subspecialty training, you know this is a high-grade tumor. So that is the ductal carcinoma. Ductal carcinoma oftentimes present as a urethra mass and lead to gross hematuria, and it's questionable whether those ductal carcinoma should be responding the same way as the adenocarcinoma. controversy data saying that, okay, maybe AR is not a key regulator in the state ductal and not responding to hormonal treatment as same as SNR, and also reports saying there's MMR deficiency increased in the ductal. But because it's so rare, so far, just small cohort, we really wait for a large, like, coordinated study to have a large cohort of pure ductal carcinoma to figure out what is their biology and what is their pathogenesis mechanism, which is difficult to do because ductal, as you know, pure ductal carcinoma is rare, very, very rare. It's a zebra. But mixed ductal and SNR is more common. So when it's mixed, how do you select your cohort? It's like 90% of SNR with 10% of ductal versus 50-50. How do you select? So those the cohort design really affect your outcome of your study. So this is difficult to study, but I hope someone genius and very collegial could do this homogeneous cohort to let us know what is truly ductal represent for. Nowadays we know it's pure ductal, you grade as 448 is a bad cancer. It's behave as the grade group 4, 448. And notice those curve-forming architecture is different than the SNR curve-forming architecture. SNR type is because of cuboidal cytoplasm, so the lumen is cookie cut round. And this, because it's a pseudostratified columnar cells, papillary branching, so the space is slit-like, irregular space. So this is the low power view. This is ductal differentiation versus SNR. So it could show some basal cells, okay? Mostly, majority is basal cell negative on the PIM4 staining, but if you see some scattered basal cells, it doesn't tell you it's not ductal. And also, the ductal subtype could travel in pre-existing benign duct. So ductal carcinoma could also be seen as intraductal spread. That's what I mentioned before, the stupidity of the terminology. Because if you call this ductal type as a different name, say endometrioid type, endometrioid or colorectal-like cancer with intraductal spread, then it's clear. A ductal cancer with intraductal spread, what is that? Anyways, so this is a ductal with intraductal spread. You see it's kind of almost intact layer of basal cell lining. Existing benign ducts are still there because the basal cells are still there, but this curve-forming pseudostratified malignant proliferation is expansile, filling up a pre-existing benign ducts. So that's the intraductal spread by ductal subtype of carcinoma. And this is even more zebra. I guess it's how to say? It's a genetic unknown zebra because it's even more rare. And people saying this, and my colleague oftentimes, is this pin-like carcinoma? Is this pin-like ductal? Basically mean the same thing. Pin-like ductal, pin-like carcinoma basically means the same thing. I prefer call it pin-like carcinoma because it avoids confusion with ductal. Ductal is bad, pin-like carcinoma is good. So I would prefer to call it pin-like carcinoma. But probably, most of you never seen this tumor. That's why it's like here say it exists, but it does exist. It's important differential diagnosis because cytologically mimics ductal carcinoma. Architecturally, it doesn't. So if you think about ductal carcinoma, but it's cystic or Gleason pattern 3, you think about pin-like carcinoma. All right. Although subtly you could see some difference, this cytology is not high-grade look. NC ratio is not that high. So it's like a tufting and look like a pin-like pseudostratified epithelium, and could form some micropapillary architecture, but does not form truly real fibrovascular papillary structure. it does not give you the florid proliferation. So that's the pin-like carcinoma. High power view, look like high-grade pin. If you do the pin 4 or basal cell marker stain, it should be no basal cell whatsoever. Okay, so it's just a mimicker of pin or of a higher grade version.
What's the stroma retraction part of that entity?
Oh, yeah. So the retraction, good observation. In the prostate cancer, actually, it was my research collaborator first noticed that. He said, oh, yeah, those invasive cancer usually have the retraction artifact. Is that reproducible? Is that pathognomonic? I said, yes, it's a good observation, but sometimes you still see intraductal carcinoma has the retraction artifact as well. So it does not give you automatic a diagnostic feature, but it's commonly you see those detachment of epithelium from the supporting stroma to cause those retraction artifacts. So on the left, pin-like carcinoma. On the right, ductal. All right, let's touch upon also intraductal because it is such a important diagnosis. We really need to be reproducible. That's why on the biopsy material, we try to be very strict to call intraductal carcinoma because intraductal carcinoma is an independent prognosticator for outcome as well as for treatment responsiveness. So it is correlated with higher grade, higher stage on the radical prostatectomy. It is predicting earlier recurrence. It's predicting a higher risk for metastasis. And if you treat the prostate with hormonal treatment, those intraductal carcinoma will be resistant to hormonal treatment, most likely. And it is also reported is resistant to radiation. So it is a prognosticator as well as a treatment specific feature that you need to recognize. So larger performing structure and basal cell retain. Criteria is on the biopsy book by Dr. Epstein is listed as such, is like malignant epithelial cells filling large glands with the preservation of basal cells with solid or dense cribriforming pattern, or if it's not solid or dense cribriforming, you need either comedal necrosis or tremendous cytological atypia. How to define tremendous cytological atypia? You find your reference in cell is a normal luminal nuclei. Times 6, you have to 6 times of the normal luminal nuclei to meet the criteria to call it intraductal carcinoma based on cytological atypia. So those are the clinical significance. And so how to define the dense cribriforming, I think still is under debate. Majority of pathologists, including me, I use 50%. And Dr. Epstein says 70%. So meaning is like within that space, 70% of that space is occupied epithelium. 30% of the space is empty. That is dense cribriforming. All right, does it really matter? In my opinion, it doesn't. I'll tell you. So this is dense cribriforming. I would say it is more than 70% of the space is occupied epithelium. So no question, it's dense cribriforming. So it's intraductal. And loose cribriforming with comedal necrosis, as long as the necrosis is true necrosis, not coagulative debris secretion, this is intraductal carcinoma. This is 6 times of normal, huge, like you think about Furman grade 4. So invasive larger cribriforming at low power, very similar to those intraductal carcinoma. To be honest, I flip a coin. If I say this is intraductal and pin 4 will show me 50%, I was wrong. So if you want to really tell larger cribriforming versus intraductal, do a pin 4 staining. On the radical prostatectomy, we do the whole mount. I don't do the P4 staining, but I look for those features that dense cribriforming cell ball roll into a pre-existing benign duct. Then I just say, oh, IDC is present. You still need to check in your synoptic report, say intraductal is present or not. So there's a lot of reports saying that atypical intraductal proliferation is actually as bad as intraductal carcinoma. That's why I say 70%, 50% is not really important. So those papers are showing you that with those, way beyond high-grade pins, florid proliferation, does not meeting the criteria of IDC, they still have the characteristics of IDC, like P10 loss. So P10 loss is kind of a late event in the progression of the prostate cancer. ERG translocation happened at pain stage. Goes to the invasion, still very rare of P10 loss. Goes to higher grade, if you stain a lot of 4 + 3 = 7, those tumor for P10, probably like 20% you will see the P10 loss. And high grade, those IAP as well as intraductal carcinoma, they could show in the report 70% we have the P10 loss. So P10 IHC, now I use routinely on the core needle biopsy if I'm debating whether it's a high-grade pin versus intraductal carcinoma. Okay, so if you see high-grade, the cribriforming, you think about potentially cribriforming high-grade pin, you throw in a P10, P10 is very good, black and white. So if it's homogeneously lost, it supports, at least you say, oh, although the criteria does not fit into the diagnosis criteria of the intraductal carcinoma, they should be considered atypical intraductal proliferation, suspicious for intraductal carcinoma, because P10 wouldn't lie. This is less our opinion is less reproducible. IHC report result is more reproducible when it's black and white. So basically just showing the AIP is similar to IDC, it's a bad actor. So I would just lower my threshold of those, 50% of the florid epithelium. If I see P10 loss, I would just call it IDC. But my colleagues still stick to the textbook. So we'll see whether I could convince them to go with my practice. Because I really respect what molecular features more than the human opinions. So time is now, 10 minutes. Probably I will stop here. Just a very one slide thing to show that in the clinical practice, because of abiraterone, enzalutamide, all those intense androgen treatment, in those biopsies from distant mets, for patients with long history of prostate cancer treated with intense androgen deprivation therapy, you just be mindful that two differential diagnoses you need to make. Okay, one is whether it's prostate primary. If it is yes, whether there is a mixture of prostate adenocarcinoma with neuroendocrine carcinoma. Because neuroendocrine carcinoma, it could be induced under selection pressure because we beat down the androgen pathway maximum to the maximum, then the cancer just use other pathways. So cancer will knock down the RB, knock down the P53, and gain the cell cycle, rapid cycling to overcome our treatment, which is AR inhibition. So all those intense androgen deprivation therapy would lead to a higher fraction of metastatic prostate cancer now is actually very bad. It's neuroendocrine carcinoma. Either it's a small cell or large cell neuroendocrine carcinoma. So you need to report it in your report by after doing 3 markers or 4 markers, neuroendocrine plus Ki67, and write down if there is a component, how much % is neuroendocrine carcinoma, and whether it's completely neuroendocrine carcinoma. So that's the take-home message of this part. Now I think this is good for question sessions. Thank you so much for your attention.
Interesting topic.
Yes, please.
So thank you very much. That was quite exciting for somebody who is not a geopathologist. You understood it. So I'm interested in your integrated report.
Yeah.
So that's why I brought up the question of PSA. Because I realized that with the information that we generate and the implication for treatment, it's becoming clear that in almost every subspecialty, the pathology plus something else is ultimately what is going to determine the treatment. And I'm a proponent of the oncologist or any clinician being able to read my report and get all that he wants, rather than reading my report and then having to go to radiology to find out what my report means, and then having to go to serology to find out what my report from the, and I think we are, uniquely positioned to be able to ensure that we're already seeing that with the molecular testing in all the, cancer things that we do. And so when you showed that MRI and everything, I was quite interested in figuring out how far can we go as pathologists, and that might also require how we train residents in being able to give a consolidated report that doesn't just say this is Gleason's grade 4+7, but this is Gleason grade 4.7 with low volume tumor and PSA of 17 equals intermediate or favorable. So that it's really complete. But I don't think there's any other specialty that is positioned to synthesize that kind of information. We already do it a lot in transplant, so we don't just say this is rejection. By the time we assign it that, we have to go in and look at what the TSA shows, what the patient's medication is, is there drop in dose of the tank and everything. And then we put the report together that when they read it, they know this patient needs this or that. So I'd like to just hear your view about going towards that degree of integration of reports.
That's a very complex question that I don't think I don't think I have a correct answer, but it will make me think how to better train our trainees and also ourselves. Like, I think really the one advice is any, like junior trainee, senior trainee, junior attending, senior attending, we really should be very alert on the clinical side. Okay, so we not only go to our pathology conferences as CAP, we try to go to, if you are practicing GU, you should go to the AUA, you should go to the ESCO, you should go to the GU ESCO to understand what is my report means to the surgeon, to the oncologist, and what they manage differently. And eliminate those details that they don't pay attention to. Like a perineural invasion on radical prostatectomy, I told my resident, don't even bother. They don't care. You don't look for it, okay? LVI, you look for it, larger peripheral structure, you look for it. So you need to know what is important for them. But you don't learn it from my pathologist didactic lectures. You learn from tumor board, you learn from your coffee break with your colleagues, you learn from challenging cases, a phone call. You learn from those professional societies outside our pathology arena. That's my first thought.
Just to clear about the MRI imaging. So usually when you already do biopsy, they give you a diagram too. Do you incorporate that diagram with the cancer and then correlate it with the MRI imaging?
Okay, that happened before. So before I landed to UCLA, the report is like 5 pages long, and you have the table, you have the narrative report, you have a diagram. So a diagram of prostate, which quadrant is systemic biopsy was from, and the cancer it is 336 is left apex, left base is 459. That introduced a lot of error because the resident copy paste from the main text diagnosis into that diagram. So nowadays, if you flip our IDR report, we don't have those diagrams made on the pathology side, However, the radiology side, they have label which core it is from which MRI location, and you could corresponding to that core, and they name it like 13-1, 13-2, 13-3. I don't care, but they will know what is the 13-1 corresponding to the MRI. And we also do those radiology, oncology correlation conferences, and our trainees sometimes go there to understand how good MRI are and how some of the MRI, like say actually they miss how to diagnose some type of the prostate cancer high grade using the multimetric MRI. So why is that? So those are the gaps we need to research. What is the morphological features, BPH, but they say it's PIRATES 5. But what is the morphological features as well genetics that is underlooked by the multiparametric MRI, but it is lethal cancer. So those are the good questions we throw at our colleagues.